Vikas sir. Sir is attached with P.D.Hinduja Hospital and Dr. Agashe Maternity and Surgical Nursing Home, Kurla. And in career highlights, sir is study group leader, advisor, member, chairperson of various national orthopedic association. And sir has been a faculty and given talks in national and international conferences, symposia, and webinars. And sir has a special interest in metabolic bone disease and osteoporosis, osteoarticular infection, osteoarticular tuberculosis, trauma, and non-hernias. So I will request Dr. Vikas sir to take over the session. Vikas sir.
Yes, thank you very much, Mr. Jitesh, Mr. Premnath, Mr. Miten Kumar, and most important, welcome to Dr. Hemant Patankar, my long-time friend. Hello, Hemant. So today we would be discussing on post-osteosynthesis infections. Little problem with my computer.
Just now you had uploaded, sir.
Yeah, can you see that?
Yeah, now it is okay.
Can you see the presentation?
Yes, sir. Very much.
Yes, sir.
That black one with black background?
Yes, yes.
Yes, sir.
Okay, great, great. Thank you. So we would be discussing post-osteosynthesis infection. And first of all, what is definition? How do you define a post-osteosynthesis infection? Related to that would be discussion on biofilm, debridement, and most important question that occurs in our mind is whether I can remove this implant or I have to remove this implant. And last but not the least is the challenge that you have removed the implant, but the infection has persisted. Then how do you go about it? So first of all, why should you define a post-osteosynthesis infection? You need to develop a roadmap as to how you will treat. And second, you need to document and research all these infections to find out what is the infection rate and finally cure rate. So you need to have documentation and research, and that would depend on how do you define post-osteosynthesis infection. The definition has evolved over a period of time. Last decade, there were three commonly used definitions: CDC, NINSS, and asepsis system. There are three different definitions. And then 2010, this hallmark paper came in. How will surgical site infection be measured to ensure high quality care for all? And hallmark means more than 7,000 trauma patients were studied. And they assessed surgical site infection or post-osteosynthesis infection using three different definitions on these 7,000 plus patients. And the infection rate was with one definition was 8.7, another definition was 11%, and third definition was 15%. So there was no reliable definition to help us as a threshold for treatment at early stages. And far more important, they warned that all these such definitions would result in apparently high rates of infection being reported. So they said that the infection rate was actually low, but using these definitions, the infection rate was very, very high, reportedly high. So they emphasized need for a single, accurate, and reproducible definition of surgical site infection. And that was published in 2018 in the Injury Journal, and they laid down confirmatory and suggestive criteria and suggested a roadmap. This is something which is extensively used all over the world today. So what is it? Obviously, even a 11th pass out would say that this is infection. There is no doubt about it. Problem occurs when you just have clinical signs. You have some radiological signs. You just have early or new onset joint effusion. Your ESR, CRP are borderline high. Then what do? Do you consider this as infection or not? And that is something that they laid down the criteria. First and foremost, they said that whether it is a confirmatory criteria or suggestive criteria, surgical exploration is needed. And then after surgical exploration, if you get phenotypically same pathogens from two separate samples or from one sample and histopathologically there is a the presence of microbe, or you have you pick up one sample, one positive sample, and the other suggestive criteria, then you consider this as fracture-related infection. So in short, whenever you suspect post-osteosynthesis infection, your aim has to be explore, debribe, and target with targeted antibiotics, not only with confirmatory criteria, but with suggestive criteria. Question is why? Everybody would say, why not give antibiotics? So the reason lies in the recent or relatively recent knowledge about biofilms. So moment you take an incision, the surgical site is flooded with bacteria which are in planktonic form and they are moving. Most of them are killed by body defense mechanisms and of course antibiotics. Now there could be a condition where the situation is favorable to bacteria. Then they start attaching to themselves and to the implant or surgical site. So they become stationary and they start recruiting more bacteria. And then they start secreting extracellular matrix, as you can see here, and start getting embedded into this. And this process takes about a week or a little more than that. As time passes, more and more bacteria get into that, and more polysaccharide gets secreted. Their metabolic rate goes down, the nutritional requirement goes down, and they start developing pathways for nutrients, and they start arranging themselves in three layers. The superficial one with highest oxygen concentration dividing well, second layer which has downgraded the metabolic activity, and the third and most important, what is called persister cells. They are about 1% of the entire colony, and they are metabolically least active, and they are just not responsive to antibiotics. So they are not necessarily resistant. They are not resistant. They just don't respond. In the sense, if you provide them with more oxygen, then they start multiplying and then they respond to antibiotics or get killed by antibiotics. So these are the ones who remain deeply situated and are generally resistant, generally responsible for recurrence of infection. So slowly it starts going into crevices, under the implants, through the fracture site, and then the antibiotics don't work. So white cells cannot penetrate, antibiotics don't work, and generally the CRP, ESR, etc. start decreasing, and you think that now the infection has come under control. However, intermittently it keeps breaking. Planktonic bacteria disperse, acute symptoms develop, and you think that patient was all right till today, and now suddenly he has developed infection. He has not developed infection. Infection was always there. The biofilms decided to burst. Now, what decides this activity of biofilm? Again, a relatively recent knowledge that they talk to each other. The bacteria communicate with each other, what is called quorum sensing. And the act of communication between microbes is this. So finally what happens, that they don't behave as a colony of single cells, but a complex multicellular being. And it works, it behaves as a multicellular organism and not just collection of unicellular cells. And they decide when to burst. They keep communicating amongst themselves and then decide that they have to lie low or they have to burst. So it is called that they are intelligent, diabolical creatures. They're terrible creatures. And once that happens, once the biofilm forms, the phagocytes try to attack the biofilms, but they cannot attack. And they get frustrated and they start going underneath the implant. So with toxins, bacterial toxins, biofilms, and frustrated phagocytes start digging into the implant and bone and cause implant cutout or implant failure, whether it is a plate or a nail or any other implant. So the idea is we must prevent persistence of infection and non-union and failure of implant. And that means we need to address them at this level. When the arrow is green or at the most yellow, that is the time when we have to address these biofilms and kill the bacteria. So how do we do that? Can we see the biofilms? No, we can't. Obviously, they are microscopic structures. When you have biofilms like this, which are seen as slimy layer, the thing is too late. You will not be able to salvage your construct. So remember, they are safe abode for bacteria, challenge for surgeons, and disaster for patients. So if you have to salvage our infection, see to it that you don't go to maturation of biofilm for exploration. We must attack early, not with empirical antibiotics, which can kill only planktonic bacteria, but with knife, so that the biofilms are taken out. You do debridement, or what is called dare in as far as arthroplasty is concerned, and then collect samples, start culture antibiotics guided by culture, and then these planktonic bacteria, which become planktonic because of your debridement, can be easily killed by targeted antibiotics, and you will be able to salvage the construct. So in short, friends, surgical site infection or post-osteosynthesis infection is difficult to define. At what stage of biofilm you can say that this is infection and this is not infection? There's a gray period, gray zone. But what is important is surgically should be performed before confirmatory criteria appear. Once confirmatory criteria appear, then it becomes very, very difficult to salvage your construct. Debridement, culture, and specific antibiotics is the foundation of salvage of infection till fracture healing. So generally, you are able to salvage only till about 6 weeks or 8 weeks. Beyond that, it would be very, very difficult to salvage the construct. Thank you, friends. So in short, I've just taken you through the definition, and now we will discuss when you can salvage the implant and when you need to take out the implant. There are no questions, then I will go ahead and discuss post-osteosynthesis infection, retain or remove the implant. Can you see the presentation now? Yellow?
Vikas sir.
Sorry, blue.
Hello.
Can you see the presentation?
Yes.
Yes, the presentation is, yeah.
Okay.
Sir,
Are there
there is
any
one
questions
question
now?
from Dr. Yes, sir. There is one question from Dr. Vishal Jain in chat box, sir.
Okay, I'll just check.
Hello.
I'll just check.
Yes, sir.
What is your experience regarding external fixator versus antibiotic impregnated implants? Everything has advantages and disadvantages. External fixator has much less chances of infection. However, if a rigid fixator is used, there are high chances of malunion and non-union. In case you want the fixator to take you to union, then you need to collapse the bone ends, what is called cortical mismatch. So the area increases and there are chances of fracture healing. The antibiotic impregnated nail, on the other hand, your debridement, especially medullary cavity, needs to be very thorough. It is far more convenient for the patient. Of course, it needs removal of antibiotic nail and reinsertion. And it generally works quite well in tibia. In femur, very often our masculate would be better. But as I said, everything has advantages and disadvantages. Every case would be different, and you need to decide which is the best for every case. Oh, there are 4 more questions. I think we will discuss this after Dr. Patankar's talk and after my second talk. So when can we retain the implant?
That's better, sir.
Yes. So when do we remove or retain the implant? See, if the fracture is united, there's no question of keeping the implant. You take it out and debride. If the fracture is in definite non-union, again, with infected non-union, you cannot keep the implant. The problem occurs when it is early post-op period. Then when do you retain the implant? So what are the guidelines? First and foremost, do you have acceptable reduction? Do you have a good implant position? Do you have a stable construct? So acceptable reduction, good position, and stable construct. If the answer to this, all this is no, like these 2 cases, then you can't retain the implant. If the infection, the surgery was done, say, 6 months ago, as we discussed, biofilm has already matured. There is no way you can keep the implant. You have to take out the implant. Thirdly, and this is something very important, if you have carbapenem resistant bugs, like sensitive to only colistin, or you have a fungal culture, or something very important, you have microbes which are resistant to biofilm active antibiotics. Now, which are biofilm active antibiotics? For gram positive, they are rifampicin, and for gram negative is ciprofloxacin. So if the bugs are resistant to these, then there is no point in continuing with implant. You remove the implant, then reinsert the implant is acceptable. But retaining the implant with biofilm active antibiotics not working is out of question. And last but not the least, you should be able to get cover for your implant as well as fracture site. Otherwise, there is no point in keeping the implant. So it boils down to construct, duration of infection, microorganism, resistance pattern, and soft tissue cover. Of course, if the patient is too toxic, then avoid keeping the implant, take it out, get rid of the infection. Or patient has multiple comorbidities, then again, there is no point in continuing with this implant, take it out and address it either by fixator or something else. Now, the idea is, how do we do that? So I'll just take you through a few cases. So this was 80 plus patient. Before that, a word about debridement. It is not only removal of pus and implant. because pus is just a byproduct or product of infection and not source of infection. So think of biofilm, think of construct, think of collecting samples, what containers you're going to use and what tests you're going to do. And after plating, think where all biofilm would be there. After nailing, again think where all biofilm will be there, not just at the sinus, but over the entire implant area. And after removal of implant, again think where can be the biofilm. You need to address all those areas. Then think which are cultures have to be done. Think of sterile leak-proof containers and no swabs for sure. And the common tests that are done. Culture as well as histopathology needs to be done in every case. So now I'll focus on this. This was an elderly female who had markedly comminuted upper end femur. I had done PFN nailing. Now this is very challenging if it is your own case. And then she developed swelling. ASR was little high and ultrasound picked up about 50 cc collection. Now what do I do? Should I aspirate or should I give only antibiotics or should I explore? Now we explored on 12th day. Here you can see the that was the construct. The construct was stable because I had put in that lesser trochanter into the medial cortical defect. So though from outside it appears that it is unstable, you will realize that the lesser trochanter has gone into the defect, increasing the significant stability significantly. So at this stage, when we explored, I realized that the lateral wall was from inside was covered with granular tissue, and then I excised the lateral wall. Sensitivity was, it was not sensitive to methicillin, and we treated her with teicoplanin and rifampicin. Now remember, rifampicin is never to be given alone. Number two, start only after about 10 days when the bacterial load decreases. And last but not the least, the dose is much more. It's about 300 to 450 twice a day and not once a day. This is at 8 weeks. This is at 9 months and 2 years. We could salvage the fixation. Another one, middle-aged female with infection in the lower end tibia or Pott's fracture. That's the history. And this is how she presented to us at about 4 weeks. The surgeon had taken a swab. It was again MRSA. Appropriate antibiotics were on. And this was at 4 weeks when she came. There was a bead of pus at the lower end incision. So we excised the incision. When you're doing a debridement for infection, excise the incision. As you can see here, the construct was stable. This was only bleeding tissues remaining. And we gave appropriate antibiotics. We could cover at second sitting, applied VAC. And this is at 5 weeks with healed incision. And this is at 14 months. At 14 months follow-up, completely consolidated fracture with excellent range of movement. Similar region, obvious infection, again, very aggressive debridement. If you are able to do a cover, that means the plastic surgeon did a flap and then we could salvage. The problem is we have a very small window period when you can almost always or many times salvage the infection. What happens when it is delayed? So this patient came to us at about 2 months at 10 weeks for a second opinion. He had developed surgical site collection and discharge. He was on empirical antibiotics. And then the primary surgeon explored him at 4 weeks. The appropriate antibiotics were given. And when he presented to us at 10 weeks, there was minimal swelling, minimal pain, movements were almost full, and he was walking full weight bearing without pain. So all in all, it appeared that the infection has come under control, and therefore we decided to continue with the construct. And eventually he united at 9 months. The problem is, what happens later? Are we going to take out this plate at 9 months? Obviously, nobody wants to undergo second surgery. The problem is, at 2 years, he came back with obvious infection, knee pain, effusion, warmth, and raised markers. And MRI showed a significant infection lower in femur. So we took out the plate at that time because by then the fracture had consolidated very well. But now you would see on removal of the plate, extreme infection at lower end femur. So debridement had to be very thorough. The distal part of the bone almost had to come out. Here you can see everything had to come out, which corresponds to the MRI finding. And this is a clean surgical site. Appropriate antibiotics were given, and he is very, very comfortable. So when it is delayed, there is often a problem. Last case, she presented at 8 weeks with a large swelling. This is the X-ray. The aspiration was done by primary surgeon in OT at 6 weeks, and the culture was Proteus vulgaris sensitive to meropenem, no oral option available. And at 8 weeks, you can see there is a large swelling. Only good thing was, even though at presentation, rather the first X-ray is not very impressive at all. In fact, there is varus, the implant position is not acceptable. But when she presented to me at 6 weeks, she had already started throwing callus and she was very, very comfortable. So we decided to salvage the infection, or at least attempt the salvage. Excised, we took the D incision where we excised both the incisions. Large hematoma was found. We debrided it thoroughly, inserted absorbable, resorbable antibiotic cement, or rather CaSO4. And this is at 3 months, this is at 5 months, this is at 10 months, this is at 26 months. Very, very comfortable, and we could salvage the infection. So aggressive debridement in early stages with appropriate culture and good cover, you will be able to salvage the implant. Now, what is generally the fate of these? A very nice paper covering almost 120 patients. Within 6 weeks, if you explore, then you should be able to, from this paper, they were able to salvage 70% of the implants. However, intramedullary nails and open fractures were definite risk factors. Remember, nail and open fractures were risk factors. And they had a recurrence in 26 patients. So all in all, more than 50% of the implants had to be removed either before healing or after healing. So friends, to take home, early detection and debridement is very important. You need to consider suggestive criteria also for as an indication for exploration. So early infection, stable construct, good reduction, soft tissue cover possible, not difficult to treat organisms are, if you meet all these criteria, then there is a good chance that you will be able to salvage the implant. However, every case needs to be addressed, and these 2 articles are excellent for decision making. Thank you, friends. Thank you very much. And I think we will first request Dr. Hemant Patankar to discuss his topic on hand splints, and then we will discuss the questions.
Yeah,
Dr. Hemant?
Yeah, yes, sure, sir. Sure, sir. So now, so first of all, sir, thank you so much, Vikas, sir, for such an informative session. Now, as Vikas sir suggested, our second speaker is Dr. Hemant Patankar, sir. So about Dr. Hemant Patankar, sir, sir is practicing as a consultant in hand surgery and limb reconstructive surgery from 1990. Sir is practicing currently in Rajawadi Hospital, Apollo Hospital, Jain Hospital, and about Sir total has 17 publication, such as 8 international publication as principal author, 5 as a corresponding author, and 4 as a co-author. So I am not taking much more time. So I request Dr. Hemant sir to continue the session. Hemant sir.
Yeah. Thank you, Premnath and Jitesh and Miten. Without wasting much time, I will try to share my screen now. 1 minute. I just go on my presentation. Yeah. Where am I? Yeah. Yeah. Can you see?
Yes, sir. So your screen is visible, sir.
Is it visible?
Yes, sir. Yes, sir. Your screen is visible, sir.
Yeah. So I will be speaking on indications and application of hand splints. As you all know, the word splint is very commonly used after every orthopedic surgery, but these hand splints are slightly different in the sense that they are not the ones which are routinely available in the market. Only a few of them, like the mallet finger splint, is readily available in the market. That I am not using it as a locally made splints, but all the other splints that I am going to show in this presentation are locally made, and they're not really commercially available in the true sense of the word. They're not from any branded companies, or they're actually locally made splints. The role of splints actually in the hand is for immobilization, for prevention of deformity, for correction of deformities, for and later on for mobilization or strengthening of muscles, and in some cases to protect the fingers or the hand till function is completely recovered. The properties of a good splint are that it should be user-friendly. Both the patient must be able to understand and reuse the splint or reapply the splint. The doctor must understand the splint and use it properly on the patient. It should be lightweight. It should be well padded so that none of the parts of the splint should hurt or cause any pressure, ulcerations, or skin problems to the patient. And it should be easy to wear, remove, and clean. One classification which I had used in the past for a lecture was using, because there is no real classification, there is no textbook which really describes the use of hand splints. So it's slightly difficult. And the whole topic is so vast. So I've decided to cut it down to half an hour to use this, to show the application of splints for the commonly common cases which are seen in the hand surgery. So one classification which I used in the past was splints used distal to the MP joint. So these are the splints which we use for conditions distal to the MP joint, and the splints which are used proximal to the MP joint. Actually, these are slightly complex and advanced, and I would like to present it in a different lecture, in a different format. So currently, I'm going to show the splints which are used slightly more proximal or near the MP joint or distal to the MP joint level to show the common conditions. So I have not classified this lecture into any type. So I have based it on the indications of the splint. As we know, the commonly associated word for the splint in the hand is for mallet finger. So this is the condition which is normally where easily treated, and most of the cases of mallet finger are treated with a splint. So there are, as you know, there are two types of mallet finger deformities, one with a ruptured tendon and one with a avulsion fracture. So the non-operative method for the mallet finger is nearly all the soft tissue mallets can be treated with a mallet splints, and the bony mallets which are well reduced in a splint without causing DIP joint subluxation can be treated with a mallet finger splint. Sorry. So how do you know which patient can be treated with only a splint? Suppose it's a soft tissue mallet, there is no avulsion fracture seen on the X-ray. One very important thing in a mallet finger is to take a dead lateral view. The brief of this lecture is not to show the treatment of any of the hand conditions. So, but we will have to touch upon it. Good treatment also means a good splint. So, proper planning of the patient, proper surgery, proper technique, and proper splintage generally give a very good result. So, in a soft tissue mallet, you have to check whether the patient has got active flexion, which will always be there because it's an extensor tendon injury, and you must ensure that if the patient has at least a partial active extension. If the partial active extension is confirmed, then you can treat it definitely with a mallet finger splint. This splint is commercially available in the market, and I like to use this splint. The locally made splints are not good for the treatment of mallet fingers. So I use this commercially available splint, which is a very useful splint. It's a 3-point fixation splint. It gives excellent results, as I'll show you in a further 1 or 2 cases. So one very important thing about mallet fingers is that immobilization of the pre-IP joint is not necessary, because one technique has been described where you hyperextend the DIP joint and flex the PIP joint and give a plaster. But the contracture of the PIP joint in flexion is a very disastrous condition, which is very difficult to treat. So with this splint, the immobilization of the PIP joint is not necessary, and you can treat all the mallet fingers non-operatively with this splint. These are the other commercially available splints, but I find them not very useful because of many other reasons. We cannot control the deformity. They cause ulcerations. We cannot have any, the splints generally slip off. So these are the reasons why I don't use these splints. This is the mallet finger splint which I use, and it's a 3-point fixation splint. Here you can see a case of a fracture of the distal phalanx, which has been very well reduced in a splint. One very important complication to note is that if the pressure of the central velcro here, if this pressure is very tight, you can have these pressure ulcers, or you can have the skin problems here, for which you can use a simple padding of a folded paper on the dorsum of the hand. This gives you a very excellent padding. It doesn't allow the splint to cause any pressure ulceration on the skin. So this is a simple way to avoid the complications which can be caused with this splint. So mallet finger splint, this is a static splint. This is the best conservative treatment for a mallet finger. It maintains the extension of the DIP joint. I use it continuously for 6 weeks and then intermittently for 4 to 6 weeks thereafter. This is one case where a soft tissue mallet was diagnosed, and this was treated with this mallet finger splint. Now, very important in this slide, which shows that I generally make a marking with the skin pencil or skin pen on the finger, where I tell the patient that this splint must not slip. Though this splint is very known for not slipping from its position, many times the patients may make it loose. So if they happen to make it loose, I just ensure that the patient should keep it at this place so that it does not slip, and the patient must be able to reapply it properly. So I make the skin marks on the volar side so that patient knows exactly where to reapply the splint. So this is the result after at 6 weeks. Patient has got full extension but incomplete flexion, and at 3 months with further exercises, he regains the complete flexion. This is another case treated of an avulsion fracture treated with a mallet finger splint. This is one very important method to check whether the fracture has healed. I take an X-ray in extension and flexion. When you confirm that the bone is not moving away from the distal phalanx. That means that the fracture is united in both these positions, and then you can mobilize the patient safely. Up to 40% of the joint fracture or interarticular fracture can be treated safely with this mallet finger splint, provided you don't get any hinging or there is no apex angulation at this level. The joint should be congruous all throughout, irrespective of the level of this fractured piece. So the fracture gets well approximated in a splint, it heals, and you get a very good result within 6 to 12 weeks. An extended application of the splint in a small finger, because remember that the splint available in the market is a very small size splint. So you can occasionally treat a boutonniere deformity of the little finger with this mallet finger with the same splint applied not over the DIP joint but over the PIP joint. Very important thing which I'll show in the next few slides also is that whenever we are treating a boutonniere deformity in a splint, one must ensure that the patient is able to actively flex and extend the DIP joint. Otherwise, the treatment will fail. So now we are dealing with blunt injuries of the PIP joint. These injuries are regarded as trivial because the X-ray is always normal. These are commonly most neglected because most of the time patient does not take an X-ray and doesn't come to a doctor. And he comes to a doctor only when the flexion contracture of the PIP joint occurs, which is a disabling condition and may require surgery also at times. So the warning sign in these cases is where the patient has a swelling over the dorsum of the PIP joint following any blunt injury. And if you happen to take a good lateral view, you will see a soft tissue swelling here. So that means that this patient is going to be in trouble if he is not properly treated. So there is a risk of flexion contracture, which, as I've said, is quite disabling. So a simple splint, this is what we call as the dorsal gutter splint, is applied. You keep the distal, you keep the PIP joint or proximal interphalangeal joint in extended position. As I've mentioned, you should always, whatever the joint is not involved in, generally in orthopedics, whatever joint is not involved in the problem or in the accident or in the surgery should be mobilized. So similarly, this PIP joint is kept immobile, but while permitting the DIP joint movements. So you can see that splint does not extend quite distally. The patient can still do DIP joint exercises. In addition, he can remove the splint, apply ice, and take anti-inflammatory drugs. Now, this is the one splint which we can make in everybody's clinic. A very simple way is to use a 20 ml syringe, cut it into 3 parts longitudinally, and 1/3 of that syringe splint, as per the size of the finger, can be covered with any soft tissue padding and covered with a tape and applied on the finger. Again, this splint is locally made in the clinic on the spur of the moment, but it also permits the DIP joint movements. The splint which we make or we get locally made from our local vendor are either 2 types. One is the soft tissue splint, which are used for soft tissue injuries. These are made from rubber tubes, which are padded and covered with Velcro. And these are the hard splints made from plastic tubes, which are stiff splints. These are for conditions which are where the joint is likely to, or the finger is likely to flex in spite of the splint. So in those cases, to avoid a PIP joint contracture, we use a hard dorsal gutter splints. These are the properties and qualities of the dorsal gutter splints, and they can be used for juxta-articular fractures of the PIP and DIP joints, and it also can be used to protect the repair around the PIP joint, especially while after operative treatment of boutonniere deformity. So this is the case where she presented with a impending contracture of the PIP joint. We could passively extend it, but it was again going back into flexion. So this calls for a stiff or a hard or rigid dorsal gutter splint. You can see with the splint, you can see this much of angulation. That means she is definitely at the risk of developing PIP joint contracture. And so this patient was treated with this dorsal gutter splint in addition to anti-inflammatory drugs and elevation. And another very important use of this splint is to give complete rest or immobilize the PIP joint. This was a very arthritic PIP joint which was patient was having severe pain, not relieved by any other measures. The only thing that really helped him was a splint. The dorsal gutter splint to keep this joint immobile was applied, and the patient's pain was relieved absolutely immediately. In the clinic also, he thanked me and went. So he was really in need of some rest to the joint. So again, the good old orthopedic principles of rest immobilization really work even in the hand. So this is the case of a post-traumatic boutonniere deformity where we have used this after repair. We have used this dorsal gutter splint. You can see that this splint permits the active range of the DIP joint. It protects the repaired tendon and prevents the recurrence of deformity. Of course, this splint cannot be used immediately after the post-operative period. It should be used or it can be applied to be applied only after wound healing. So this you can see that patient is recovering active flexion, and this is the active extension after treatment of boutonniere deformity. That's the pre-op for comparison. So now you have cases where there is a soft tissue injuries, or this is a sugarcane roller injury, very light one, not a very deep one injury. Only thing is that this patient is having a tendency for unsafe position of the hand. That's the MP joint are going into extension and PIP joints are going into flexion. This is not a very good position to start with because this can lead to a crippling deformity. But the treatment of this is also a splint, but it's very cumbersome to apply 4 splints on the hand or 4 dorsal gutter splints on each of the fingers. So we use this idea. This is after the dressing of the wounds, we just cover it with a soft padding, and the fingers, all the 4 fingers are pressed together or kept together with 2, I would say, cardboard pads, cardboards on either side of the hand, on the volar and dorsal side, and covered with a tape. So this gives you that required position of PIP joint extension and MP joint flexion. Of course, this elevation and anti-inflammatory drugs are very important in all the cases. So this we call it as a sandwich splint. It prevents flexion contraction of the PIP and DIP joint. It's a soft splint actually. It permits mobilization of the hand even in cases of minimal injuries. So what happens if this patient present late? So the patient, when they present late, they present with these flexion contractures which cannot be treated. The active and passive extension of the joint, of the PIP joint, is not possible. This is a simple test where the passive extension is very painful. You try to extend the joint and patient gets very severe pain. So no pain, no gain. So this is a very good thing which tells us that this contracture is stretchable, but it cannot be stretched with a dorsal gutter splint. So these contractures which are amenable to a stretch pain, where you can stretch out the joint, but the patient gets pain, that means a very good sign that the patient can get treated with a Kapner spring splint. There's no need for surgery. You have to teach the patient that you have to look out for capillary filling. You have to look out for pain. You have to make the patient wait in your clinic. Tell him how to adjust the splint. And this patient did very well with the splint. So these are the Kapner springs. These are basically flexor resist and extensor assist splints. These are dynamic splints. This work mainly on the PIP joint for prevention and correction of deformity. This protect the extensor repairs over the fingers with simultaneous mobilization, especially in boutonniere deformities. And it also is very useful for mobilization and strengthening of the flexor tendon after repair or grafting. We'll see a few examples. This is a case of a PIP joint flexion contracture. This was initially, I've applied a splint. Now I always tell the patient, you remember this number 1 and number 2 positions. Number 1 position is where the splint works maximum, gives the maximum stretch, but it can give the maximum pain and probably sometimes vascular problems. So if the patient gets pain, you have to shift this splint to the number 2 position. That means that the hinge of the splint should be shifted proximally. That reduces the stress or the tightness of the splint or the temper of the splint, and even the patient is able to then start moving the finger with the splint. So if you want more strength or more power with the spring, you have to shift the splint slightly distally at the level of the PIP joint. If you want lesser power with the splint, you have to shift it proximally, and that gives you a very good correction. So a few examples where the splint is very useful. This is a case of jersey finger, operated, treated with a screw. Now the patient at the end of 6 weeks all these patients, these are flexor zone 1 injuries. They will present with deformity and stiffness. They will have adhesions and contracture following surgery, which is natural. So this splint is a very strong splint in the sense of the word that the finger cannot tolerate the pressure. If the fracture is not united, if the tendon repair is not perfect, then this splint can undo the fracture or the tendon repair. So you should apply it safely after about 5 to 6 weeks. I have applied after 6 weeks. Now this splint is applied on the finger when the swelling also is come down, and patient is able to do active exercise with the splint, and this passively stretches the finger, and this is the result. You can see again a fracture of the base of the proximal phalanx. Any disparity with the proximal phalanx will cause focal point of adhesions, and the flexor tendon will get stuck. Like this case, this is not the ideal way of treating of these fractures. You can see that the spike is left behind. So this caused this contracture. This patient presented late, so not amenable to a splint. So was treated with a flexor tenolysis and followed up with a splint. This splint is used in the post-operative period to prevent further or recurrence of the contracture. So it's a very useful splint in that way. Again, this is a case of a post-traumatic scar contracture is in a sugarcane roller injury. And this initial stretching of the contractures was achieved very nicely with this Kapner splints. So this splint, as I have mentioned, is a flexor resist splint, and this is also useful to assist the extension. Like this case of a very small avulsion fracture seen causing a boutonniere deformity. This Elson's test is positive here, as you can see. This was treated in a mallet finger. I would say a Kapner spring. You can see this padded on this side. This padding is the newspaper or any paper folded here to prevent pressure ulcerations on this finger, on the skin, because the dorsal skin, as you all know, is very thin. So again, very important, this splint should not extend distal to the DIP joint so as to permit active flexion and extension exercises of the finger with the splint on. And it can result in a very good, it can give a very good result. You can see that the complete extension, active extension is possible with complete flexion. So that this means that the boutonniere deformity is completely healed with this splint. Again, a case where there is a extensor tendon injury with this fracture, treated with repair. Now, post-operatively, you will always have a lag of the extensor. After the fracture union is confirmed, you apply this assist splint or the Kapner splint to assist the extension, and that's the result. Again, in this case of a fracture of the proximal phalanx treated operatively, this patient, all the patients will always have adhesions and weakness of the extensor tendons following this sort of repairs. So after the fracture union is confirmed, I repeat, you should apply this Kapner spring splint. It gives excellent results. So what to watch out for? When you are using a Kapner splint, make sure that your distal circulation is intact before the patient leaves your OPD or your hospital. If it is there, then either your splint is very strong, you have to readjust the splint, make it or give a splint of a lesser temper, or initially you have to treat it in a different way till the finger is fit enough to be fitted with a Kapner spring splint. Again, I have shown you, I have already mentioned that any pressure points of the splint should be covered with any newspaper. Don't use cotton, don't use cloth, don't use bandage, use only newspaper. This is another point where I have already shown that this also can give a source of pressure and should be covered with a folded newspaper. So finger extension contracture again is a very disabling condition. Now this patient was treated for a closed dislocation with a close reduction. Unfortunately, this patient did not follow up with the doctor, just treated elsewhere, and patient landed up with a finger which was stiff in extension. He was not able to completely flex the finger. So in this case, what I use is called as a finger flapper. This name has been coined by me. It's not, as I said, available commercially or is for sale in a branded market. So this finger flapper is used keeping the wrist static, keeping the wrist stable. You can use these rubber bands on the finger. This is just a splint which is having a Velcro on these two sides, which passively flexes the finger. the advantage of this splint is your patient can actively extend the finger, and this gives a very good result. You can see that the full active extension and active flexion is restored by using a simple finger flapper. So the basis of all the splints which cause wrist or cause finger or MP joint flexion is this static splint, or also called as a short T splint. Basically, it's a splint which has 3 velcros. Basically, all the splints in the hand will work best if there is a 3-point fixation. Same way, these are 3 velcro straps which are well padded from the inside, and these are wrist immobilizers which are very useful as a base to keep the wrist immobile for the finger flappers or the MP joint flexions. Of course, these splints are made side specific because, as you know, the arch of the metacarpals curves on towards the side of the little finger. So these have to be right and left specific splints. So this was a case which was having a flexor tendon injury in the zone 2. He'll require flexor tendon grafting, but unless the finger is supple, you cannot do a grafting because the grafting would fail. So this was treated with the finger flappers. The finger is softened up, the PIP joint and DIP joint are stretched out gradually with the splint, and then this patient is treated with a grafting, and that's the result. Again, this patient, very interesting. Patient presented was going to various doctors and therapists for 2 years without any positive outcome. He presented to me with 3 fingers which were absolutely stiff. The MP joint was supple, but the PIP and DIP joints were absolutely stiff. This was treated with these 3 finger flappers. The finger flappers were applied individually to all the 3 fingers, and that's the result. I think at the end of 2 months, he was completely relieved, and that's no swelling. You can see the fingers are completely functional, and he's absolutely painless and a very happy patient. So, and another condition which we treat very commonly, or which we are very scared of in hand, is the MP joint stiffness. These are cases where they are very easy to treat if you are diagnosed it easily, diagnosed it early, but very difficult to treat. Very important is to have a safe position in the plaster post-operatively for various conditions in the hand or various conditions of the hand and wrist. It's better to have a safe position in the plaster. To prevent MP joint stiffness, you have to have active exercises of the patient immediately post-operatively, and of course use the MP slings. So what is the safe position? It was described by James in 1960, about 60 years ago now. And that is a safe position of the hand is where the PIP joint is extended, MP joint is flexed, the wrist is extended, and thumb is abducted. So one should always aim for the safe position in the hand. The unsafe position is exactly opposite this. In addition, I would add that a shoulder adduction and internal rotation also is unsafe because it's a precursor of a shoulder hand syndrome. So many times we see a patient with a blunt injury around the wrist or blunt injury trauma to the hand, patient present with the stiff MP joints and adduction contracture of the thumb. So this is only out of sheer neglect or probably of, I would say, not taking attention to the patient or giving attention to the patient. Patient presents with a stiff MP joint. So here we treat it again with a short T splint to stabilize the wrist, and then you apply slings on the MP joint to gradually force the MP joints into flexion and gradually pull out the thumb into abduction. So the MP slings are for traction on the fingers to prevent and to treat MP joint contractures as mentioned in this slide. So this was a case where the metacarpal neck fracture was treated with a retrograde wire, not very desirable method in my opinion. Wire was removed, and this patient, young boy, presented with a very stiff MP joint of the index finger. So this was treated with this traction slings, the MP slings, and went on to give a very good result. So initially, in all the MP joint contractures, you should try with MP slings. Only if you get a dimpling or if you get a dimple around the MP joint area, that means that this contracture is not going to stretch out with the splint and it may require surgery. But still, it's worth trying with these MP slings. Don't try with passive manipulation. You may end up cracking the metacarpal head. So this is a MP joint contracture following a post-fasciotomy. And this was treated with these MP slings and went on to give a good result. This was a bench press injury. Now, this is a case where after treatment, this is going to be having an impending contracture. This was treated appropriately. Now, this is what I call as a preemptive splinting. You anticipate that patient is going to have an MP joint contracture. You splint it with gentle rubber bands. And that is after about 10 days when the initial pain of the surgery and the injury is reduced. Then you start gradually stretching this. Don't wait for the hand to become completely all right, or don't wait for the fracture to heal. You can use these splints immediately after about 10 to 12 days, and you'll get a very good result. So a patient does not have to follow up for a longer time and can get back to work very fast. This was a very interesting case. Is a young girl with a polio, the upper limb. He has a flail thumb. There is no opponents here. I did opponentsplasty using an extensor indicis tendon. And to maintain the tension of the tendon transfer, I used these splints to maintain the abduction of the thumb. And you can see a very good result. That's the active abduction or active extension. That is the active abduction of the hand opposition in this hand. You can see even the MP joints of the finger are very supple again. So this, again, very interesting case. Patient presented with the inability to actively extend the fingers. He had a neglected injury to the dorsum of the wrist. On exploration, we find that all the extensors are cut and it was repaired. Now, in this case in particular, you have to give a volar slab to protect the repair. Now, when you give a volar slab, which I have already mentioned, you will invariably develop some MP joint flexion, MP joint contracture that is in extension. So you anticipate the MP joint extension contracture following this repair. So after 4 weeks, when you expect that the tendon repair is slightly mature and the sutures are holding well, you start gently flexing the fingers with this MP joint, that's the MP joint pulleys, to assist the flexion. However, in this case also, now since you have already started flexing the MP joints, you should start extending the joints, or you should help the extensors, because actually the cases of extensor tendon injury. So you should assist the extension by this 4-finger spring splint. So what is this 4-finger spring splint? It's a not so strong dynamic splint. It prevents flexion contractions of the MP joints and IP joints, and also prevents first wave adduction contracture. It is very useful for mild contractures. It mobilizes and strengthens the flexor repairs and is very useful to protect the extensor tendon repairs. Now, this case where there is a EPL rupture following fracture of the distal radius, a repair was done and the extensor repair was protected with this dynamic splint. Now, the advantage of this splint is like a Kleiner's traction. The advantage in this particular case is that patient can actively flex the thumb, but passively there is no load or no tension on the suture line. So it gives you active flexion and passive extension for the hand, for the thumb in particular. So this is a very good extensor assist splint for EPL ruptures or EPL injuries. It gives a very good result. Again, this case of an extensor hood injury of the middle finger, ring finger was repaired, treated in a volar slab for 4 weeks, and then followed it with this short 4-finger spring splint. Now you can see in this, the spring should not extend. The spring should be adjusted in such a way that it should not extend beyond the PIP joint.
Hemant, you have become mute.
I have become mute.
No, sir. Sir is very much audible, sir.
We are able to hear him. Please
Hello?
continue.
Hello?
Sir, your voice is very much audible, so you continue, sir.
Okay. Sorry, sir. So in this case, one must ensure that the splint does not extend beyond the PIP joints, because our main intention is to protect the extensor repair, but at the same time allow active PIP and DIP joint movements. So this splint should be, the place where you apply the splint also has to be taken into consideration. So this went on to give a very good healing. Now this again a case where there is a crush injury of the hand with associated metacarpal fractures. This patient had a digital nerve injury, flexor tendon injury, compound fractures, which was treated with intramedullary nailing. And now to overcome the flexor adhesions, overcome the skin contractures, overcome the flexor tendon to skin contractures, we use this splint after 6 weeks, and you can see a very good result in this patient. Now this was a case where there is an incomplete flexion of the middle finger, as you can see, and when we explored, you find that all the tendons of the flexor tendons of the deep tendons are cut, and of course it was treated with an appropriate repair. And at the end of 3 weeks, we find that the patient is unable to completely flex, which is natural, and is unable to completely extend. So adhesions after flexor tendon injury or repair are known. So you passively or you actively mobilize the patient, let the patient actively mobilize between 3 to 6 weeks. And at the end of 6 weeks, you give this 4-finger spring splint. The advantage of this is a very soft splint. It's a mild, having a mild temper, and it allows the patient to actively flex, but still gives you passive stretching of the flexor tendons. So gives a very good result. So this is a case of a crush injury at the web, at level of the first web. The index finger is crushed beyond repair. So we amputated the index finger. And now what we anticipate in this patient is an adduction contraction of the thumb, which can be quite disabling. So after the wound has healed, or when the healing stage of the wound has occurred, when the graft has taken well, you apply this splint and prevent the thumb from coming into the web. So prevent an adduction contracture of the thumb. So this gives, you can see we have prevented further surgeries or further morbidity of the hand by giving this 4-finger spring splint used on the thumb. So this 4-finger spring splint again is a very useful splint. You can see many times we see patients with a radial nerve palsy. They come with such a cumbersome assembly on the hand. So this splint works as a dynamic cock-up splint for radial nerve palsies also. So this is the last example where I'll show use of these multiple splints for this case of a flexor tendon injury when all the 4 fingers were involved. This was a case about 15-20 years ago. I treated him. Came with only a skin suture. We explored and found that all the flexor tendons were cut. And you can see this tendon and nerve repair was done. Post-operatively, I give a nail traction. And I like to use this Kleinert's method of mobilization for flexor tendon, which means that patient is allowed to actively extend the fingers, but passively flex. With the rubber bands, he passively flexes the finger. This goes on for about 3 weeks. Between 3 to 6 weeks, I ask the patient to only actively move the fan, actively extend as much as possible, actively flex as much as possible without giving any splint. At the same time, we massage the wound, give him anti-inflammatory drugs, and also intermittent elevation of the hand. So at 6 weeks, I give a Bunnell's block splint. The Bunnell's block is basically a block for the MP joint movements, so that the patient with a flexor tendon repair is able to actively flex the PIP and DIP joint only. So the forces of the repair don't concentrate on the MP joint. So this is given between 3 to 6 weeks. And after 6 weeks, you start gradually stretching the gradually stretching the repair, gradually stretching the adhesions. So to give full extension, and eventually to strengthen the flexor tendons to give full flexion. But this is only after 6 weeks. None of these spring splints should be applied on the hand before 6 weeks. After about 3 months, patient can use multiple springs that are available in the routine in the market. This is the spring which I prefer for flexor tendon repair. And you can see that a very good result at 4 years post-op. So basically, for the hand, one must diagnose the condition, one must plan the treatment, execute it perfectly, be it tendon repair, fracture repair, and then anticipate what problems can occur and be ready with those appropriate splints to get a good result. I thank you all for your attention.
Thank you very much, sir. Thank you very much. We will start taking the questions now. We have with us Dr. Vishal Shinde, Vishal Jain, sir. Dr. Vishal has raised his hand, so I will allow him to talk. Sir, you can unmute and you can ask your questions. There are many questions you have in line. So, Vishal sir, are you there?
Hello.
Yeah. Yes, sir. You can please ask the
sir, please, sir, share your experience in compound fracture, grade 3 tibia, and what should be the decision, either external fixator or fixed and flap technique, because it can cause infection later on. So, what is your experience?
Hello.
Will you choose external fixator
me?
or? Yes, sir. I can hear you.
Can you hear me?
Yes, sir.
Yes, sir. Yes.
Yeah, Dr. Vishal, please go ahead.
Sir, what will you the first choice if you are having compound grade 3 fracture, compound fracture tibia? You will go for external fixator or fix and flap technique?
This question too.
Dr. Agashe. Dr. Agashe.
Yes.
Hello, can you all hear
Agashe,
me
sir.
or no?
Yes, yes.
Sir, we can hear you.
So Dr. Vishal has got a question for you. Can you hear us or no, sir?
Sir, can you hear me, sir? Can you hear me? Or if not, then you can read my question. It is in question and answer inbox.
Sir, you are unable to hear us, but we are
Yes.
able to.
Okay, so can I take questions?
Yeah, you can talk.
Sir, it is already in question and answer inbox.
Okay, done. So shall I start taking questions?
Yes, please.
Okay,
Please.
okay. So I'll start taking questions. Is your protocol for compound fractures grade 3B with fix and flap technique and success rate? Overall, fixed and flap technique has some definite criteria, and generally it is safer not to use it for 3B. It is safer up to 3A. Beyond that, it is possibly better to use external fixator initially, followed by some kind of internal fixation. But day one, fix and flap for grade 3B is little risky. Till we get, Dr. Umar Farooq Baba has asked, till we get sensitivity report, can't we use broad spectrum antibiotics depending on local sensitivity? Perfect. So essentially, there are 5 different classes of antibiotics. One is one is prophylactic antibiotic, which we give for surgery on closed fractures or closed injuries, which are generally given only for 24 hours and 3 doses only. Broad spectrum antibiotic and generally useful for skin flora. Generally used for skin flora. Second are preemptive antibiotics, which are given after open fractures. So though we often say that we give prophylactic antibiotic for open fractures, they are actually preemptive antibiotics because the microbes have already entered the body. Prophylactic are given when microbes have not entered the body, so that antibiotic can keep waiting for bugs and kill it. Then if the infection develops, and you debride, then as Dr. Umar has said, can we give broad spectrum antibiotics? Yes, these are empirical antibiotics to be used till your culture sensitivity reports are available. After they are available, then you start appropriate antibiotics or targeted antibiotics. Last and the fifth class is what is called suppressive antibiotics, which are used when the implant is still inside. The infection to some extent is there. You are suppressing the infection till fracture heals, or in case of joint replacement, you want to continue it for a long time. So yes, if you have you encounter a case of infection, you have debrided it and waiting for culture sensitivity report, you can use empirical antibiotics. If implant gets infected after 2 to 3 months, there is a partial sign of union, then what should you do? Should we wait for union or should we remove the implant? Again, these 4 criteria. Is the implant stable? Number 2, is the soft tissue cover very good? Number 3, has the construct has been explored and debrided and appropriate antibiotics are given, and the culture pattern or sensitivity pattern is useful for us. If there's a distinct instability, then there is no point in keeping it. So you need to keep assessing stability. If the stability goes on improving, then you may continue the implant. If there was a grade 3 compound fracture and we operated with intramedullary nailing, after 10 to 12 days, there was a serous discharge. What should we do next? Should we continue with the nail and antibiotics after pus culture and sensitivity, or should we remove the implant and apply external fixator? Now, especially grade 3 fracture, you have done an intramedullary nailing. If there is a discharge, then it is very, very likely that it is getting infected. It is always safer to at least do a very thorough debridement locally as well as along the nail. If you think that this discharge is this, here you have written serous discharge, maybe you can just remove the nail, ream and put it again. But if it is a definitely infected discharge, then if the culture becomes positive, then it is safer that you take out the nail, do an external fixator, and maybe continue the construct in external fixator till fracture healing. Distal tibial fracture with exposed plate and surgical site is dry and union is not complete. Very, very occasionally, you will have this situation that the distal tibia plate is exposed, but the wound is absolutely dry. Yes, it is known. It totally depends on when you have encountered this. If you have encountered this within first few days, then maybe you could hold on and do a flap. But otherwise, either you have encountered it late, say at 5 months, it is quite likely that you will continue the plate till the fracture heals. Okay. If you have encountered it early and it is infected, then it is best to take out the implant. I don't think there is any other question.
So in question answer section, it is all, that was the last question. We have some questions over here in chat box also. I'll open it and read out for the speakers. Dr. Harsh Shah, suggestions of removal of implant over the spine recently operated tends to be difficult to to be accepted both by operating spine surgeons and the patients. So what would you recommend to approach a SSI for such case with long implants instruments?
So the first and foremost is don't give empirical antibiotics. If you think there is a discharge, slightest doubt of infection, especially in spine, where, as you rightly said, that you will not like to take out the implant, then don't suppress the infection with antibiotics. Explore, do a thorough debridement and close. You might be able to salvage the implant. If you go down within about 3-4 weeks, you'll be able to salvage the implant. The problem occurs when the surgeon tries to suppress the infection with antibiotics. 1, 2nd, 3rd, and then the infection becomes long-standing. By the time you explore, then it is too late. So early exploration is the key.
Then there are a lot of compliments to both of you. Jabardast, Majedar, these, that, and so many comments. There is a question now. It is necessary to do dressing on 3rd to 5th day in a clean soft tissue surgery. For example, in tendon transfers.
I think it is for Dr. Patankar.
Yeah, probably.
Yeah, actually, the dressing is necessary because generally there is always post-operative bleeding, and the gauze pieces and the material can get stuck there. So it's better to do a dressing between 3rd and 4th, 5th day. And again, secondly, if you're planning to mobilize fast, then with a minimal dressing, you can start mobilizing, because initially after the post-operative period, one generally tends to apply a lot of compression, a lot of fluffy cotton, gauze, and so many things. So in that way, it is better to get rid of the blood-soaked gauze and apply clean gauze and make sure that your everything is going on well. And you can start the mobilization program depending on what tendon transfer you have done. So I think it's better to do at least one dressing immediately post-op, and then you can continue with the mobilization. There's no need or urgency for suture removal, but at least one dressing should be done.
Thank you so much, sir. This question is again for Dr. Vikas, sir.
Yes, I think this is experience of supercutaneous locking compression. Am I right?
Yeah.
Plate in the treatment of infected non-union open fractures of leg versus external fixator. Now, this plate can be used as an external fixator, especially in the distal area where you are not likely to have a big segment distally. See, if you have a decent segment proximally and distally, then fixator is definitely better. If you have a very small segment distally, then you can use a distal tibia locking plate, or if you have a small fragment proximally, then you can use a proximal tibia plate. The problem often occurs is the wound pattern. You need to have a decent space in case the wound is not very good and you need to do a flap cover. Then this becomes difficult. But if you have already done a flap cover, you don't have anything much to do, then you can use this as an external fixator. But if you have a decent fragment on both sides, then I'll prefer an external fixator. The reason, okay, let me explain the reason. With external fixator, you can put rod-to-rod clamps and put your shank screws wherever you want and still reduce it and dock. As regards this plate is concerned, you have a fixed area where you have to put screws. They have to be perfectly in one plane, and you can't really reduce it after you have put the fixator.
Thank you so much, sir. There's a question from Dr. Hitesh. Patients had maybe lower limb plating done and flap done. Persistent infections. Plates removed gradually. Osteomyelitis, bone deprived and filled with bone stimulant. But there is persistent serous discharge in this case. What to do?
Okay. Persistent infection, plates removed gradually means one after another, probably he's saying. Osteomyelitic bone debrided and filled with bone stimulant. There is a persistent serous discharge. Now, there are two things. One is serous discharge after stimulant is well known. That is the way it acts. It dissolves and gives antibiotics locally. So if there is significant stimulant, especially in the subcutaneous area or near the skin, there is bound to be serous discharge for about 4 to 6 weeks. It can be as commonly found as, say, 15 to 20%. That generally, it's not generally, it is not associated with signs of infection, fever, redness, and pain. It generally serous discharge only and settles in about, as I said, 4 to 6 weeks. If the discharge is purulent, then the debridement has been inadequate and you need to explore and debribe again. Only for stimulant discharge, which is serous, you need not explore. It just stops by itself.
Thank you, sir. Thank you so much. Final
local installation of antibiotic like vancomycin, useful for, you need to have a carrier for that, which would be either MMA, PAMA, or stimulant, or occasionally allograft. But you need a carrier which will keep the antibiotic elution for a long time. Otherwise, if you just instill, it is not likely to be very useful because it would disappear in no time.
Your experience of a local intra-wound administration of powdered antibiotic in orthopedic surgery.
Correct. Same thing. Unless you have a carrier, it will not last you long. Just installation locally is not very useful.
Dr. Samarth Ajay Thakkar, can stimulant be freely used in joint cavity when dealing with the chronic septic arthritis, infected implants within joint cavity?
There is no harm in using stimulant in the joint. It is not likely to damage the articular surface. However, all these local antibiotics would work well when there is no macroscopic infection. You can't blame the stimulant or any other type of local antibiotic if the debridement is inadequate. It is not in place for debridement. But yes, it will not damage the articular surface. There have been studies where people have inserted and there is no damage.
So that was the last question, sir. I think it's time to...
I'll read it out. After debridement and stimulant insertion, do you place a drain or should we avoid it? Draining the fluid out may reduce the efficacy of stimulant. Perfect. There is no definite answer to this. I read it at in one or two journals. After that, what we have started doing is keep the drain on, use drain only when necessary, keep the drain on and off, on for about 15-20 minutes and off for about 3 hours. Exactly how much is the drain of antibiotic is very difficult to know. But this is what we have been doing with good success. So 3 hours, we keep the drain closed, open it for 15 minutes, and then again keep it closed for 3 hours.
Dr. Pushkar Khandekar is asking that there is any role of ORIF or primary flap coverage in grade 3 fractures?
So remember, we get carried away by implants. The most important thing in all this is debridement. To the extent that now British Orthopaedic Association and plastic surgery people have said that don't use the word debridement, use the word excision and extension. So you need to excise the wound, you need to extend the wound so that you are able to excise this better. So only that you can think. And another very important thing there is wound debridement or excision and internal fixation or external fixation are two different procedures. So you do thorough debridement, take out all the drapings, change your trolleys, prepare drape again, change your gloves, not just gloves, wash up again, and with new instruments, fix it. So these two are considered as two different procedures and not debride and put an internal fixation. That is number one. Number two, only if you are absolutely sure that you have done a good debridement, then you can proceed with both these. It is no doubt excellent way of managing it. I would very often do, what I do is I use WAC for about 48 hours, go down at 48 hours and then do a flap. Number two is very often these flaps that are needed are microvascular flaps, and we often do not have access to microvascular surgeons. So yes, on paper, it is useful. In many places, people put WAC for 48 hours or at least keep the wound open and do a flap, do an early flap. That is at 48 hours or so.
Dr. Shankla is asking what is the rationale behind off and on drain?
There is, honestly, as I said, I have read it somewhere. There is no rationale. I cannot prove it. What I am doing is right or wrong. But I mean, this is one way of doing it. I don't have an experimental proof for that. I just feel that the stimulant will not be sucked out. I don't know whether I'm right or wrong.
So that was the last question.
Last question. Very good.
I thank both of you, Dr. Agashe sir and Hemant sir. Thank you so much for a wonderful and very, very informative. The way the responses is just pouring it into the chat box and the question answer box. Appreciating the talk and sharing the knowledge, which have been a prime objective of Janssen Pharma also. Sharing of knowledge. So thank you so much for giving such a wonderful lectures on the respective topics. I also thanks my Janssen colleagues to get quite a good number of attendees also. Then of course our admin help from Mr. Mitain. And thank you all participants and thanks Janssen colleague and thank you sir. Any passing remark, Dr. Patankar sir, you want to give?
I am most thrilled to hear Dr. Agashe. It's been we are not, I'm not doing lower limbs and the type of trauma that he is doing, but his lecture has been an eye-opener to me.
Sir, Agashe sir.
Thank you. I'm honored, and for the information of delegates, I don't manage hand injuries at all. All my hand injury cases go to Dr. Patankar. Thank you very much for managing my patients as well as myself. And thank you, Janssen, for organizing this webinar. Thanks a lot. See you
Thank you.
sometime
Thank you.
in near future. Bye-bye.
Sure, definitely. Good night. Good night, sir.
Good
Take
night.
care.
Good night.
Yes.
Recording stopped.